Yeah, I think that, that's a very important point. Like we were talking about at the beginning, the criteria for Olympia were designed to risk stratify, not because there was a biological difference between somebody who had 3 nodes and 4 nodes, right? So, it was purely a risk stratification for the purposes of trial design. And I think what you're trying to do in the clinic is find a person who has sufficient risk that they may benefit. And if I recall, the label actually for olaparib is high risk. The olaparib doesn't talk about the entry criteria for Olympia.
It's sort of broadly, you define it.
Exactly.
Labeling, right?
Exactly.
Yeah.
So Olympia defined safety and efficacy, and then now the clinician is the one who makes the decision about whether or not the risk is sufficient to potentially generate benefit. And so your paradigm of if they got enough risk for a CDK4-6 inhibitor, they got enough risk for a PARP inhibitor makes perfectly good sense to me. It's kind of like what we used to do in clinic, right?